And let's now move to the whole subject then of tonight's meeting. What I should like to say first of all is how pleased we are at the Linnean Society to have this continuing collaboration between various organisations. Our speaker, as I'll say in a minute, comes not only from the Natural History Museum, but from a prestigious organisation in Washington. We have the Linnean Society, and of course this is held jointly with the Royal Society of Medicine. And this Darwin lecture, of course, is going to be dealing with a subject that, although it deals with aspects of global health and dealing with childhood survival, the aspect is dealing partly with things like the evolution of helminths, the worms, and these organisms that affect health in human beings. So there is this beautiful sort of bringing together of these various subjects and various organizations. Tonight we have the pleasure of Professor Judd Walson. He's a principal research fellow, as I say, at the Natural History Museum. A professor, this is going to take a long time, but it's up there if you can read it, of global health, medicine, infectious disease, pediatrics, and epidemiology at the University of Washington in Seattle, in the States. I say that he has extensive experience in the design and implementation of large clinical trials in resource-limited settings, and is particularly interested in the effects of enteric infection and composition on childhood survival, immunological function and growth. And I'm told that the lecture will highlight on targeting children's underlying vulnerabilities with specific interventions designed to address mechanisms underlying individual risk, which we're all, of course, concerned with, which may offer the opportunity to significantly impact growth and cognitive development while also averting deaths. So it is to warmly welcome you again and to invite Professor Judd Walson to give his talk, which I'd better read the title. Actually, it's up there. It's easier for you to read it yourselves. So, Judd, would you please like to address us? Thank you very much.
Thank you. It's a pleasure to be here, and I'm excited to be able to walk you through this talk. When I was looking to come, my daughter, who's 13, asked me how many people would be at the talk. I'm glad that there are a lot of people here. And I said, I don't know, let me go online and look. And when I went on the website, it said that it was full, and it was completely full. So you couldn't register anymore. Registration was closed. And I told my daughter that, and she said, wow, that's impressive. You know, Justin Bieber doesn't sell out all his concerts. So I thought that was a pretty good start. So good to see you all. I'm going to start this talk today with this photo, because now this photo was taken of me on the far right several years ago. So this was 1991, I believe, in Nepal. And of course, when I took the picture because I was thrilled to be part of this community, and I'll tell you a little bit more about that, with no sense of what this photo would mean in the future. But looking back on this picture, it's quite interesting, because this photo actually summarizes a number of key elements that have led my path and my career, and really have helped to shape my interest in childhood vulnerability. So the first, of course, is my time in Nepal. I studied cultural anthropology, actually, as an undergraduate in university, and went off to Nepal to do a small research project for a few months, which lasted almost 3 years, and really enjoyed my time. I worked tracing patients who defaulted from medical care, among other things, in very remote villages. So the village where this was taken required a one-day bus trip from the capital, and then a 4 to 5 day walk to reach. So these are quite remote villages. And so I had this experience of really understanding how people in resource-limited settings lived, what were the challenges they faced. The second thing, though, that I observed was just the incredible burden of infectious diseases. Now, I was not medically trained at that time, but I saw this firsthand. I saw the impact on the community of multiple infections. In fact, one of my closest friends in the community is on your left in the white hat and the white shirt, Ang Prabha. He really helped guide me through a lot of these early years, and he ended up dying about 2 years after this photo was taken of multi-drug resistant tuberculosis. And a number of the children that you see here, also I would see recurrent pneumonias and other infections. So I started to understand that being vulnerable in this sense really was vulnerability often to infectious disease. The last thing that you see in this photo, which I completely did not appreciate at the time, and maybe not everyone will appreciate, is the effects of chronic malnutrition in setting up vulnerability. So if you look at this picture, I think most of you can see, I'll step away from the podium, I'm not a particularly gigantic NBA basketball style individual. I'm a pretty average height person. But you can see here that in this photo, I'm really just towering over all of the adults and the children in this picture, despite the fact that I'm on a slope going downhill. And yet these individuals don't look emaciated like we traditionally are led to believe, famine and malnutrition. This is a classic presentation of stunting, or a low linear growth for age. So these individuals have experienced chronic malnutrition from early childhood, leading to the inability to reach their growth potential, which in and of itself, we don't worry too much about people. We're not trying to grow tall people. But stunting is associated with high risk of mortality, poor response to vaccinations, and high risk of other morbidities like cognitive disability. And so stunting is a major global problem that I'll get to in a bit. The other thing I want to talk about just to set the stage is often when we talk about childhood survival, we talk about childhood death in low-resource settings, it is a very heavy and can be an overwhelming topic. But I think it's important to realize that actually, if you look here in red at the proportion of children who die in the first 5 years of their lives, over the last 200 years, we have made unbelievable progress in reducing mortality all over the globe. You can see that here. Why? What has driven this change? Well, I think there's a lot of things, probably economic development, improved access to health care and water and sanitation, immunization, certainly. One thing that I think really has catalyzed movement towards targeted interventions to improve health and reduce mortality and morbidity has been the United Nations really pulling together around a common set of goals. So in 2000, the United Nations brought together 189 member states to sign the Millennium Development Goals, which set clear targets and a framework for accountability for member states to address issues related to global health and development. And in 2000, that number increased to 193 member states who signed on and pledged to commit to reach these targets by 2030. And as you can see, these targets are not all health-related, but they all have important impacts on individual and population-level vulnerability. And this has, I think, made a really substantial difference in getting everyone on the same page with common goals that are well spelled out and targets that we can measure and hold people accountable to. But this progress has not been equitably distributed around the world. So you can see here on this figure that global mortality has decreased across the world in all regions, and that's something to celebrate. But Africa continues to have higher rates of mortality than anywhere else in the world, substantially higher. This is under 5 mortality. So if we look at some of those underlying vulnerabilities, poverty is one that really jumps out. And you can see here on the x-axis, this is the share of the population living in extreme poverty. That's usually defined as less than $1.90 a day. And on the y-axis, you see the mortality rate. And there's a couple of things that are quite striking here. So first of all, if you have very, very low level of extreme poverty in your country, below 5% or something, you have very, very low child mortality. But what's also interesting is that when you get up above 30%, 20% extreme poverty, you uniformly end up with very high child mortality. So poverty clearly is a major driver. But it's not just at the national level. Even within countries and within regions and within districts and administrative units, there's tremendous variability. I've just taken the first country in the WHO report here, Brazil, and plotted out infant mortality and child mortality against consumption quintiles. So consumption quintile is just a measure of family welfare. And as you can see here, it's pretty striking. Even within the country of Brazil, the poorest quintile has over a 5-fold increased risk of child mortality than the richest quintile. So even within countries, we see these disparities. It's not just the rates of mortality, it's also causes of mortality.
If we look at the socioeconomic, social developmental index that the Global Burden of Disease Study at the Institute of Health Metrics and Evaluation has put out, this is an index that combines wealth, fertility, and educational attainment. So it's a composite measure. If we look at countries with a very high SDI, you can see causes of death displayed here, where the size of the box is the relative contribution of that cause, and the color reflects the type of cause. So blue being non-communicable diseases, green being injuries, and red encompassing infectious, neonatal, maternal, or nutritional causes of death. So this is what it looks like in places like the UK and the US, where we have a high SDI. So under 5 mortality is largely preterm births, congenital abnormalities, a little bit of injuries. That's pretty much what it looks like. But if we look at what this looks like in low socio-development indice countries, you can see it's strikingly different. So first of all, the burden that's related to infectious disease is astronomically higher, right? So here you can see lower respiratory infection, or LRI, pneumonias, diarrhea, measles. All of these infectious causes now take up most of this box. And the non-communicable diseases and the congenital abnormalities are shoved into a tiny sliver of the cause of death. So really, when we're talking about causes of death in under 5 children, it's very dependent not only on where you are geographically in the world, but also within regions. It's very variable. And this just highlights this. This is more data from the Institute for Health Metrics and Evaluation at the University of Washington, which has now plotted subnational data down to the 5 kilometer by 5 kilometer scale to look at child mortality across the globe. What's interesting here is that, first of all, as a benchmark, the target for the Sustainable Development Goals in target 3.2 for child mortality is for every country to reduce child mortality to less than 25 per 1,000 live births. That's the target for 2030, okay? So you can see here that would be purple. So you see here already that on the left, you see the map of Africa plotted by administrative unit, not by country, but administrative units within country, and then that's just removed on the right for ease of viewing. So you can see there's just a very small area in southern Africa that's on track to meet these targets. And there's these huge belts where you have under 5 mortality rates approaching or exceeding 200 per 1,000, where we're not even close to considering that. And this is another interesting way to visualize it from another study in another group. So here you see Africa in 3 figures. On the left, you see annualized rates of change in under 5 mortality from the 90s and to the 2000s. The dark blue areas have seen a drop of 5 to 10% over that time, while the darker red areas have seen an increase in mortality of the same magnitude, 5 to 10%. So quite different. In the middle, you see the annualized rate of change in mortality needed to achieve the mortality rate below the target for the SDGs in 2030 on the basis of estimates of under 5 mortality in the 2000s. And on the far right, you see the difference between where they have been in terms of the rate and where they need to get to, which suggests that the areas here in dark red need to accelerate under 5 mortality declines by over 10% a year in order to meet those targets. So, what are we going to do about it? What are the interventions that we can consider to try to address this? So many highly successful interventions that we use in public health rely on a broad population coverage in order to reach those most vulnerable. So if you look at this schematic, I've just outlined that children here in red would represent the highest risk children. Those in yellow or gray, I guess on this screen, would be moderate risk children, and the blue would be the low risk children. And so often what we do is we sort of blanket try to cover the population so that we get those red children covered while reaching them. But this clearly isn't always the most efficient way. Now, for some interventions like vaccination, you get indirect benefits by covering all the children, and so this type of approach makes complete sense. But for other interventions where you really are targeting the exact individual who serves to benefit from that intervention, this may not make the most sense. So, I just want to talk a little bit about these interventions that we use. So some of the most commonly used interventions in public health really don't reach those who need them most. So on the top left, you'll see coverage of the third dose of the diphtheria, tetanus, pertussis vaccine. So this is a standard vaccine delivered all over the world to children. And you'll see this as a percent of the eligible pediatric population, which is disaggregated by country and by wealth index within the country. And what's really striking here is how low some of the coverage rates actually are in countries with the highest mortality. On this chart, countries such as Pakistan and Nigeria are exceptionally high mortality countries, and you can see that coverage is low in those, reaches low levels. And who does it reach the lowest levels in? The lowest wealth quintiles. So you see that coverage doesn't even reach 10% in some of those populations. On the bottom right, you see another chart which depicts global coverage of common interventions that are stratified by wealth quintile. And again, this is by individual intervention. I don't know if you can see them all, but here you have like full immunization coverage. Here you have insecticide-treated bed nights, skilled birth attendants. So different types of interventions stratified by wealth index across countries. And what you see here is that some interventions do deliver high coverage, but they're almost always inequitably distributed. And those that achieve equity almost always are equitable because everybody's getting low coverage. So it's a real interesting phenomenon that with increasing coverage, we also see increasing inequity. And this is just another way to look at this across the life cycle of an individual. So where in the life cycle are we reaching high coverage? And you can see here that interventions that target pregnancy and early infancy tend to get the highest coverage. And that's great. That's because women are accessing facility care more in those settings, probably, and that's why you're seeing the higher coverage. But as I said earlier, if you remember that chart from Brazil that showed the big difference between infant mortality and under 5 mortality, you'll see here that the post-infancy coverage of interventions commonly delivered to that age group are strikingly low. So, as the number of highly vulnerable children in a population is decreasing as we lower mortality, which is a good thing, the effectiveness and cost implications of blanket coverage of the population to reach a few become less and less clear. And targeted interventions to reach those in greatest need become more and more attractive. And this is really what's referred to as precision public health. So Richard Horton, the editor of The Lancet, has a nice quote. He says, "Precision public health is about using the best available data to target more effectively and more efficiently interventions of all kinds to those most in need." So targeting these populations, of course, needs data. If we don't have data, we can't guide decision-making, and we also need, in addition to the data, the ability to act on the data, which requires the ability to analyze the data. So today I'm going to talk about 3 studies that our research group is doing or involved with, and that I think all address different aspects of this targeted approach. Obviously, they told me I had to finish by midnight, so I can't go into too much detail on each of these studies. I could speak for hours on each of these studies, so they're quite complicated. All of these have websites that you can look up by name, and they all have published protocols that you can look up by name. So I'd encourage you, if you're interested in more detail, to please look at that. First, I'm going to talk about a study that's being done and coordinated by the Natural History Museum here in London called the D13 Study, which is really looking at optimizing a platform for equitable coverage. Then I'm going to talk about the Childhood Acute Illness and Nutrition Network, or CHAIN, which is really trying to identify who are the most vulnerable individuals and what are the mechanisms underlying their vulnerability. And then lastly, I'm going to talk about a randomized trial that's being conducted in Kenya, trying to target some specific mechanisms in a group of exceptionally highly vulnerable children. So, neglected tropical diseases. I just mentioned deworm 3, which is all about deworming. Why neglected tropical diseases? Well, when we talk about vulnerability, we're often talking about neglected populations who failed to realize the economic, political benefits of the places where they live. And identifying the features of those populations can be challenging because they come from very diverse geographic, cultural, political, social groups within countries. So what framework can we use to be able to say this group is likely to be more vulnerable than that group? So poverty is one, but poverty also can be challenging to assess in some situations because poverty can be relative to the place where you live. But what we do have are a group of diseases called neglected tropical diseases. And this is a group of between 13 and 21 diseases, depending on who you ask, that traditionally have been thought as neglected diseases because they were neglected in terms of research, they were neglected in terms of funding. But they also, interestingly, happen to be incredibly good markers of very neglected populations. If you find a community with a neglected tropical disease, you have, by definition, found the most disadvantaged community in that area. And that is true for most of the neglected tropical diseases. So on the top left, you see a table which compares the burden of these diseases to other prevalent diseases in Africa. And while NTDs, they don't cause death, mortality in the same degree as HIV or TB, they do result in a lot of morbidity, including anemia, delayed cognitive development, reduced economic potential, and other morbidities. The Institute for Health Metrics, again, and Evaluation, reports that the global burden of disease study in terms of mortality, but also in terms of a metric that includes morbidity, and that's the disability-adjusted life year, a DALY. And a DALY is just the sum of the years of life lost and the years of life lived with a disability. And so really what a DALY is one lost year of healthy life. That's what a DALY is. And you can see here that the DALY totals for these NTDs are not insubstantial. They're really quite a significant burden on people's lives. On the right, you see a distribution of some of these NTDs. These are the ones that we commonly use mass drug administration or preventative chemotherapy, that's the PC here, to treat these diseases. So it's a limited group of these diseases. And you can see the distribution where the darkest red on this map represents areas where there are 4 or more of these diseases endemic in that population. So again, as a marker, if you look again at that map I showed you earlier of Africa of under 5 mortality, you can just see visually how much overlap there is between areas where vulnerability to mortality exists and areas where these diseases are prevalent. And one of the most common of these diseases, in fact, it's probably the most common infectious disease of humans, are the soil-transmitted helminths, or the intestinal worms. So probably about a third or a quarter to a third of the world is infected with intestinal parasites. I'm not going to call out which third of the room it is, but I often say there are kind of 2 kinds of people in the world, those that know they have worms and those that don't. So you can see here that the numbers of individuals requiring treatment to prevent these diseases, so people living in endemic areas, exceeds 2 billion individuals around the planet. The guidelines for these, interestingly, that WHO has put together really focus on controlling the morbidity associated with these infections. So we use mass drug administration of a drug called albendazole or mebendazole. We treat children, and we reduce the burden of their infection to a low enough level that they don't suffer the morbid consequences. And we decide who gets treated based on the prevalence of disease in the population of children in those communities. And I want to just say that this strategy has been incredibly effective at reducing morbidity associated with these diseases. However, while this is very successful in reducing morbidity in the highest risk children, there might be some reasons we might want to consider alternative approaches. So first of all, the current strategy focuses on treatment largely through schools, and it's delivered by teachers in schools, which is great because you have a highly accessible population of children that you can treat. However, if we think about who's likely to be the most vulnerable child in a population, it's likely to be the child who isn't in school, precisely because the reason they're not in school probably has something to do with their vulnerability. And so we often see very low coverage in non-school-going children in these communities. Of course, preschool-age children are included in the strategy, but evidence suggests that they rarely actually are covered in such high levels as the school-age children in these settings. In addition, there's a number of studies that actually show if you treat adults in the community as well, you actually lower the prevalence also in the children. So there's indirect benefits to the children. Finally, there's another reason, and this is work done by Roy Anderson over at Imperial College and his group. The current approach focusing on treating the children will never interrupt the transmission of these diseases. The children will go back home after being treated, and they'll be rapidly reinfected by the adults in their households. Particularly hookworm infection, which is one of these infections, which peaks in terms of age in young adulthood, where you see the highest levels of infection, who are not being targeted by the current strategy. So in the middle figure, you'll see that treatment of children, either annually or biannually, annually or biannually in red or blue, does actually reduce the burden of disease in children, as you would expect. But in adults over here, treatment of children, either annually or biannually, does very little to reduce the burden in those adults, as you would expect. And overall then in the population, if you just treat annually or biannually the children, you have very little impact on the burden in the overall community. So you have to keep deworming indefinitely, or at least until enough development has happened that you're reaching sort of levels of 1950s Europe and the United States of sanitation and economic development, which is not likely to happen in my lifetime in many settings that we're working in. In the green line, you see what happens when you actually treat the entire community, including the adults. And you can see that actually several rounds can rapidly reduce infection down, we think, maybe to levels that would actually interrupt the transmission of these worms. There's a large study. Several of the investigators, I see Kate Halliday here from London School, who was involved in this study, the Tumikia study, which has just been completed in Kenya, which also showed that actually this sort of community-wide deworming platform, which is reaching, again, the most vulnerable, is actually quite equitably distributing coverage. So here you can see, just looking at preschool age, school age, adolescent girls, or adults, very high levels of coverage across all of those groups. Here you see poor versus least poor, toilet, no toilet, remote, accessible, fairly equitable coverage, which is not seen in all platforms. So both as a platform to deal with worms, but maybe even more importantly, as we start to think about targeting interventions to the most vulnerable, does this mass drug administration platform have a role? Sorry, it's quite counterintuitive to hit the down button to go forward. So I'm going to talk a little bit about the D13 study here. This is the study we're doing at the Natural History Museum. The D13 study is a study with 3 core objectives, really focused on whether we can break the transmission of these worms. And breaking transmission may be quite important, and I'll talk about that in a moment. First of all, to break transmission, we have to know what we're measuring. How do we define breaking transmission epidemiologically? And then operationally, how do we measure it? Secondly, we have to demonstrate that it's possible. And thirdly, we have to work closely with the World Health Organization and governments, ministries of health, to understand if we're successful in using this platform to do this, how do we scale this rapidly? Because currently, the average time before a researcher like myself demonstrating that something works and it actually being applied successfully in the field is somewhere between 13 and 17 years. And we don't want to wait 17 years because we're, for many reasons, one of which is we're well beyond the SDG target deadline at that point. So we need to be able to act quickly. So this is just a chart showing you all of the players involved in this very, very large study, D13, which is coordinated by the Natural History Museum across the world, from the University of Washington, London School of Hygiene and Tropical Medicine, Swiss TPH, Imperial College, Smith College, a number of others. And then this study is being conducted in 3 sites in Benin, India, and Malawi. And you can see that here. The idea here is to leverage another NTD platform which has been in place in these settings for quite some time, the lymphatic filariasis program. It's another disease that's treated, incidentally, with the same drug, albendazole, in combination with other drugs. And so many places have actually moved towards elimination by treating, in many of these communities, annually with albendazole everyone in the community. So they're already giving us a head start. And what D13 is doing is coming on the tail end of the LF program and initiating biannual, community-wide mass drug administration with albendazole to see if we can get the prevalence of these infections low enough that the likelihood of these worms replicating is sufficiently low in the population that we break transmission. And these worms are interesting because actually, in order for these worms to reproduce, you have to have a male worm and a female worm meet each other in the same human host, and then they have to have sex and have baby worms, well, they have eggs, which then have to be shed into the environment, and then they have to reinfect a human in order to complete the life cycle. You can't actually have auto-infection within the human host. So if you're infected with 3 worms, the most worms you can have from those 3 worms is 3 worms, unless you ingest further from the environment. And so because of that, statistically, if you can get the probability in the population of those two worms finding each other in the same human host low enough, you can break transmission. And so this study is a large community cluster randomized trial where we take each of these countries and we divide the study region into 40 clusters, half of which, 20 clusters, get biannual treatment, and half of which get the current standard of care, treating in the schools, either annually or biannually. And that's depicted up here. And we treat for 3 years, and then we stop treatment, and we wait 2 years with no treatment to see if there's a bounce back of infection or if we've cleared them. And the goal here is really to help WHO develop guidelines around their strategy for worms. But of course, there are multiple other goals. We might find that we can break transmission everywhere. That would be beautiful. The guidelines change. We deworm everyone with the goal of breaking transmission. Possible. We might find we can't break transmission. No matter how hard we try, sanitation is such a problem. All these other things are such a problem. We just can't get there. In which case, the current guidelines may need to be put in place for a while. Or we might find that there are some areas where you can break transmission and some areas where you can't. And understanding what are the features that enable a community to break transmission would allow us to have guidelines that say, if you meet these criteria, let's say you have open defecation rates less than 50%, or you have, poverty, extreme poverty less than X%, then you should move towards elimination. Otherwise, stick with the current protocol. And that's really what this is about. So just to give you a little bit of an update and some sense of the scale of this. So we've currently enrolled about 365,000 individuals in this study across these study sites. You can see that the population demographics are quite different. This is a population pyramid with each of the bars representing an age group, under 5, 5 to 9, 10 to 14, et cetera, all the way up to 99. We stop at 99. And you can see here that these population pyramids are quite different, strikingly different. In India, you have a lot more older individuals than you see in Africa, in either of the African sites. And in Malawi, you see this big divot that's been taken out of the adult male population and the older adolescents to the younger adult males. That's likely because they're all off in other countries or in the capital away for work, so they don't live in their communities. So you can really learn a lot from these population pyramids. We also can see tremendous differences in some features of these areas. So this is, India actually is divided into 2 areas, a tribal area, region, called the Jawadu Hills, and a lowland plains area called Timri, and then you have Malawi and Benin. And here you see rates of open defecation, with the dark red representing higher than 90% open defecation rates. And you can see in Jawadu Hills in India, there are simply no use of sanitation facilities, all open defecation. Whereas in Malawi, you see it's about 2% open defecation rates, so very low levels in Malawi. But that's really interesting, because if you look at a good indicator of socioeconomic status, which we look at floor material as one marker, we could look at a variety of other things, but floor material, actually Malawi is by far the poorest of these communities. And yet, they are able to achieve very low rates of open defecation. So again, this just gets to what are those features that are going to be more important in our ability to break transmission. Just to give you a sense of how much infection, we deliberately chose areas with moderate levels of infection, not excessively high areas of infection. So you can see here, this is any of the worms. These are the specific worms by type. And you can see here that India has by far the highest infection rates. Most of the infections are relatively low intensity. That's very common in these types of settings, although there are some high intensity infections in Benin. And again, similar to what I showed you over, as a platform, how does this perform? So this is from the first round of mass drug administration in the D13 study, and you can see, I'm sorry, the formatting here looks like it was knocked off. These are about 90% and about 93%, I believe, in these two. 89% and 93%, I believe, actually. Sorry about that. And a little bit lower in Malawi. But you can see that those are the coverage levels. And just looking at India, you can see that actually the vast majority of individuals were actually able to directly observe their therapy. So whether or not they're taking their drug becomes less of an issue. And this is of major importance. I promised the organizers that I would mention the words evolutionary biology at least once in the talk. And this is where I get to bring it in. And that is really that if we look in the veterinary world where these drugs are commonly used to deworm animals, there is massive, massive drug resistance that has evolved because of the drug pressures. And we haven't observed that yet in humans, probably because we haven't looked. And I'm sure in the next few years, we're going to start to see the emergence of resistance to these drugs. And so ensuring that the populations are achieving high coverage is really critical and fundamental to ensuring that you're reducing the risk of emergence of drug resistance as much as possible. And again, just to highlight, the distribution of coverage is quite equitable across these populations. I'm going to move a little quickly here, just to point out that chemotherapy coverage here is so high for these diseases that it's actually approaching the universal health coverage targets set by the WHO. And again, that's against, if you compare that line of coverage, or these lines of coverage, to those other childhood interventions. So I'm going to change courses and talk a little bit about the Childhood Acute Illness and Nutrition Network, which is really now looking at, can we target illness specifically in children? So here I want to point out, this is if any of us had a child, many of us probably do have children, I have 3 of them, and we imagine our child going along in their usual state of health, and then all of a sudden they become ill. They get, let's say, pneumonia. They drop down in their health status, measured here, to a level that's so sick that they require hospitalization. Let's just say that's what that line means. Our expectation is that we go to the hospital, they get treated, and they rebound back to a normal level of health, just as they were before. That's pretty much what we expect in a high-resource setting. But the settings that we're talking about are profoundly different. There's a lot of contamination of the environment with pathogens, whether it's in an urban slum from sewage, whether it's in a rural area from agricultural contamination, whether it's shared water sources. These areas have frequent exposure to pathogens. And so what you see in these settings is not this single drop in recovery. You see that children start off lower, largely because women enter pregnancy with lower nutritional status, with frequent infections themselves, et cetera. And then they get hit with repeated pathogen challenges until they get low enough to be admitted to the hospital or see a physician or a healthcare worker. They recover, but they never recover back to where they're supposed to be. They just constantly get hit with these challenges. And so they kind of hover along this trajectory of low health. And we know some features of vulnerability. We know that young age is a major marker of vulnerability. High risk of death the younger you are. The problem with age is that it's not a modifiable risk factor. We can't treat age, right? We know that low anthropometry, or markers of malnutrition, is highly associated with death. But we don't know why. So being malnourished is associated with risk, but it doesn't tell us anything about the mechanism by which that risk occurs. And then finally, acute illness. Children who have one acute illness are at incredibly high risk of death in the subsequent year. And this just shows that. So first of all, on the left, just to show where does the death occur. So many people assume that kids die in Africa because they don't get health care. And in fact, that's increasingly not the case, even in countries of the poorest countries in Africa, like Chad and Niger, where less than 20% of children, when they're ill, are actually not seeking health care in a health facility. So most children are seeking care, some are not, but most die in the hospital or after a sizable number after they go home. This is a survival curve that just shows the proportion of children still alive after leaving the hospital out to about a year by nutritional status. So normally nourished children, moderately malnourished, severely malnourished. You can see severely malnourished children have strikingly high mortality in the year following leaving the hospital. After the doctor says you're good to go home, that's how much they're dying. And even normally nourished children are dying at a rate of about 5%. 1 in 20 children, normally nourished child, dying in the year after discharge from hospital. So why are they dying? Well, there's lots of potential mechanisms. From social issues, we see lots of issues with maternal mental health issues. We see issues with neglect, as young single mothers have to leave their children alone for many hours to go find work to try to feed their family. We see lots of issues around enteropathy and immune dysfunction. We see issues around the way that they're treated in the hospital, their acute care, all sorts of things. And so the chain network that I mentioned is really trying to explore all of these to identify the underlying mechanisms for morbidity and mortality. The study is actually powered for mortality, and it's being conducted in 9 sites across 6 countries in Africa and South Asia, all of which are relatively high mortality settings. So you can see here the distribution of those sites. And basically what we're doing is enrolling children. Each site enrolls 500 children when they come to the hospital. and they're admitted for being severely ill. They're stratified enrollment, so we get 200 severely malnourished, 200 moderately malnourished, 100 non-malnourished. And we're measuring malnutrition using a middle upper arm circumference, or MUAC, which is listed here as the criteria if you're interested in the numbers. And we follow them through their hospitalization, through discharge if they survive, and then out to 180 days to try to understand what happens to them. We collect throughout this process an incredible amount of data, everything from household social factors, water and sanitation data, maternal mental health. We do qualitative interviews with all of the families to get a little bit more detail about the social science. We collect a host of biological samples, including blood, urine, stool, hair, all sorts of things. In some sites, we're collecting PBMCs for immunological studies. It's a huge wealth of data and information to try to understand these risks. And you can see here we've enrolled about 365 children to date. Some of these represent some community participants who are not ill that we use to sort of understand what the community norms are. And I'll get to that in a second. But you can see just the age range here in months of those enrolled. And you can see pretty equal distribution across the malnourished to normally nourished children. And here you can see just by site what the mortality rate looks like. This is the survival curve from day of enrollment, so through hospitalization and out to 200 days. And what you can see here is astoundingly high mortality, as would be expected, particularly given that we're enrolling children with malnutrition. But in some sites in Kenya, for example, as high as 21% of the 1 in 5 children that we enroll in this study is dying within a year. So it's quite striking. And here you can see if we disaggregate by nutritional status, again, severe is here. And if we look at Africa versus Asia, Africa is quite a bit higher in terms of mortality. The other thing I want to, actually I'll point that out in just a moment, but here I want to point out, this is quite disconcerting. So I'm a clinician, and I'd like to think that my clinical training prepared me to be able to identify who was at risk and who was not. But what we're seeing here, if we look at the actual mortality across different groups of children, we can see that those clinicians are pretty much predicting risk. We ask the clinicians when the child's admitted to hospital, what do you think this child's risk of dying in the next year is? Tell us what you think it is. And you can see here that actually they're not very good at detecting who's at high risk. They may be picking up some of the very, very high risk kids because these ones are largely unconscious and comatose. But other than that, they're really not very good at picking up risk. There are some differences in the hospital stay. The mean length of stay is about 5 days, a little longer for the sickest, but it's not reflected in the perception of the physicians. And what we're able to do with all this data, and I'm just showing a simple classification and regression tree analysis here, where we've taken data just on basic admission data, nothing fancy. We've thrown it into a model and said, tell us what groups come out as highest risk and lowest groups, reasonably sized groups. And you can see here, we can find groups in here that are exceptionally low risk. These kids have very, very low risk, and it's a large group of them. It's about 70% of the kids. Very low risk. They don't need to be in the hospital. We're probably giving them more infections by keeping them in the hospital than they need. They probably would do better going home earlier. And then there's a group of children with exceptionally high mortality. And we can find those kids, and we can start to now say, well, what is underlying this that might be a mechanism for intervention? I've shown you a very simplistic version of this. We're also using some complicated computer learning, machine learning algorithms to try to refine this a little bit. And this would take me all night to explain. But basically, if you look at these SHAP values, what you see here in pink, this represents high risk. Blue represents low risk. So for middle upper arm circumference, if you have a low MUAC, you're at very high risk. If you have a high MUAC, you're at low risk. And you can see if your consciousness level is very low, if you have an impaired consciousness level, you are very high risk. So this just starts to allow us to do that. And what we can do with that is then look at groups that cluster for the same reasons into groups. And we can find groups that are very, very low mortality, again, big groups, find high mortality groups, and we can find moderate groups. So this now allows us to say, if a child is admitted to hospital, which are the children that you really need to worry about, and what are the mechanisms that we need to deal with to reduce mortality in this group? So one of those mechanisms is social vulnerability. This is a study funded by the Gates Foundation, and I think this is something that they're really more interested in, some of the biological interventions that we can do. But I'll tell you, some of the most interesting things from my point of view have been the impact of maternal mental health and the impact of social factors around the discharge time that I think are really interesting. Here you can see, if you look at children who either abscond from the hospital, this means they sneak out without paying, or they leave against medical advice. So they're seen, but they just leave against advice. Represents almost 10% of our population. It's not a small number. The rates of death in that group is exceptionally high. And why do people leave the hospital before they're ready? Largely because A, they can't pay the bill. B, they have other kids at home who need attention and they need to get back to them. These are social issues. They're not biological issues. All the antibiotics in the world are not going to cure this problem. This is a different type of problem, and we can start to address that. So what we're starting to do now is come and start to stratify these into different types of interventions that may affect mortality, either in the hospital or out of the hospital, growth, and other outcomes. And we can start to envision ways that we could get children out of the hospital early. We could escalate care for the most ill. We could target post-discharge support for some of these children. These are all viable alternatives. So lastly, I'm just going to give you some insight into a very specific randomized trial that we're conducting, the Totobora Trial, which is really trying to look at this post-discharge death a little bit more closely. So why do kids die after hospital? I hate to say it, but I think a lot of it might be us. I think we are putting children in a culture tube, essentially, in the hospital, where we are exposing them to all sorts of bad infections. And I think many of these children are actually acquiring their fatal infections in the hospital. We also see the emergence of antibiotic resistance of their untreated infections and treated infections with persistent long-term impacts on our ability to manage those children afterwards. We see children are vulnerable. They have some immune paralysis after they get sick, and they get repeated infections. And then there's a whole host of non-infectious inflammatory conditions that affect these children, one of which is enteric dysfunction. This is a well-described phenomenon that was seen in Peace Corps workers returning from Africa in the 1960s, where they did biopsies to understand why these American kids were losing weight tremendously. What they found was that this combination of poor diet and a dirty, fecally contaminated environment produces blunting of the villi in your intestines and a lot of inflammation with translocation of bacteria across the gut barrier. So you get systemic and local inflammation, you get bacteria getting into your bloodstream, and you blunt your body's ability to absorb nutrients. So you make malnutrition worse, you drive up your metabolic demands with inflammation, and you expose children to pathogens. And this is a really important syndrome that's emerging as a major cause of stunting and of death in these children. So what we're looking at is really trying to address this enteropathy, some of the immune issues, and some of the infectious issues by looking at an antibiotic intervention. So this study came out in March. I was not an investigator on the study. I was the chair of their Data Safety Monitoring Board. But this is a large study in 3 countries designed to evaluate whether or not mass drug administration of an antibiotic, azithromycin, giving it to all the children in a community could reduce childhood mortality. And in fact, they found a 14% mortality reduction in children receiving azithromycin, in the communities who received azithromycin. Pretty astounding. The effect was most pronounced in the younger age group and most pronounced in Niger. But the study was not designed primarily to look at these subgroups. It was really designed as an overall study, 14% mortality reduction. So my mind, thinking about precision public health, said, well, that's great. It looks like it works, but do we really want to expose all these kids to an antibiotic to benefit a few who are going to likely die? The risk of antibiotic resistance, this is from another study in a trachoma endemic area where they use azithromycin. You can see in the group of villages that got mass drug administration with azithro, rapid emergence of resistance to azithromycin. And this is in the non-MDA villages. So still had some, but it was pretty stable over that time point. So we know we're going to drive up resistance with this. So could we target this? So the Totobora trial is simply randomizing children at very high risk of death at hospital discharge to receive azithromycin or placebo, and then following them again for 6 months. And the idea here is maybe we can refine this strategy to a group of children at particularly high risk. We don't have to expose the entire community. So I'm going to wrap up, and I'm happy to answer some questions, but I just want to leave you with a few thoughts. First of all, we've seen tremendous progress in reducing child mortality globally, and we should really all recognize that, because I don't think it's appreciated as much as it should be. But the residual deaths that now occur are much, much more difficult to address. We've got all the low-hanging fruit off the tree already. What's left is hard, and we have to start thinking about targeting it. We also need to think about what are the platforms that we can use that are most likely to actually reach the kids we want to reach. Because while a lot of programs are out there and there's a lot of platforms, we can see, as I showed you earlier, they don't all equitably reach children in need. And finally, we really have to go beyond this sort of blanket approach to identifying which subgroups of which children are at what risk, for what reason, and target those mechanisms. Some of them will be social, some of them will be biological, but this is the only way we're really going to be able to address the residual mortality, I believe. So I'm going to leave you with this quote, because I think it's a great quote. I think it really speaks to sort of the philosophy that I think is needed to move beyond this. And I want to thank, just in particular, all of the women and children. You can imagine with mortality rates this high, we deal with a lot. Our study staff in these countries deal with quite a lot to manage these issues and these vulnerabilities. I want to thank the kids and the moms who've participated in these studies. They've really offered themselves so that we can learn more. I can't possibly go through the list of everybody who's involved in these studies. These are massive studies, but I just want to acknowledge the institutions and the individuals who've been involved. I see Kate in the room, and she's been very much involved in the D13 study as well. And so I just want to acknowledge that for everyone here. And with that, I will stop, and I'm happy to answer questions.